And you can see my PowerPoint slide, I hope.
We can.
Okay, well, good. Then I can get down to trying to start my presentation. Hello, everybody. Glad you're here. And it's a little bit different than the kind of presentations I normally do. Generally, I'm with a live audience, and hopefully you're all live, but you're just not here in the same place as me. So I appreciate you sending me any messages or anything that you'd like addressed if it looks like I'm passing over it, so we can make sure that we try to cover what everybody wants. Anything I don't get to today, I will definitely try to get back to you by email or some other manner. Okay, anyhow, starting out, of course, this is not directly relating to finance, asking why the organization is here, but we've got a few slides of background so we can try to put this fiscal stuff into perspective of the bigger picture of what we're trying to accomplish at the health centers. Okay. And we start out with our vision. And I mean, the vision is the highest level of what we're trying to achieve at the health center. And it would be something that in a perfect world we'd be able to do. Usually it's something like improving the health of the community, or if we're serving just farm workers or some part of the population, improving the health of the people that we're responsible for. Our strategy is the overall plan of how we're going to make our vision happen. As the board, you generally would be participating in more general terms. We don't expect you to know all the ins and outs of providing health care, but you should hear the general strategy that management is taking on, and hopefully you will understand it and agree with it, and the staff should fill in the blanks for you. Also, you and the staff shouldn't be afraid to get outside help when you need it, because the world of healthcare is getting increasingly complicated. Execution is basically the part where the management and the staff carry out the strategy to make your vision happen. And generally, the board, you get progress reports monthly on how they're doing with it, but you're generally not very involved. And compliance is something we hear more and more about these days with all the rules that we have to follow. We're going to talk about some of what are called the 19 requirements, which is what the federal government puts out for us. It's sort of their federal version of the 10 Commandments, only being the U.S. federal government, they had to have more, so there's 19 of them. And there's all sorts of other rules and laws that affect health centers, the IRS, your local government, the organizations that pay you, and more compliance is a big part of providing health care. And we'll explain that a little bit more as we get farther into the presentation. So as the board, you're generally wondering, okay, so how do you fit in to this picture? And I start out with the vision. You notice that it's in color. There's two colors. The one on the right is supposed to be magenta, so that would go with management. So the more of it that's lavender, that would be the governing board proportion of it, and the smaller box to the right would be management. So the vision generally comes from the board. You get together, you put together a strategic plan, hopefully a vision of what you'd like to see, and then you recruit a CEO and management that help you shape it, that hopefully share your vision. Strategy is sort of half and half between the board and management, and the people that you hire to do this for you will bring in some knowledge of healthcare and health center industry in general, and you as the board will tell them which way you'd like to see the organization go. And particularly the user board members are important this way, because you represent the actual patients that are getting the care, and somebody has to be able to speak up for them to make sure their needs are being met. Execution. So that doesn't mean we're going to kill any of the board members that don't do a good job. What that means is that the staff has to execute the strategy, and you can see it's mostly staff, a little bit of board input, and monitoring of it, and you just want to see reports on how things are coming along. And as far as the compliance that we discussed earlier, again, it's mostly on you, and that's because you are the legal entity that's responsible for everything that happens. So even if you don't understand all of the details of what's going on, you at least have to be comfortable that somebody's minding the store. And again, we'll talk about that a little bit more as we get farther into the presentation. As far as what's required of you, and it really is not, it's not as much as people would think. Obviously, you joined the board, so that was the first part. You cared enough about the health center and the community to join the board. You need to participate. And, you know, as Woody Allen said, 80% of success is showing up. So you have to be at the meetings. And I mean, I've worked with some boards where there's board members that, for whatever reason, get busy and can't attend. And if you have a lot of people on your board that aren't there, then you're not getting their input, and they're not really helping move the ball forward. The other way you can participate is to sit on board committees. Hopefully your board has a number of committees, and the one that we're concerned with today will be the Finance Committee. I'll talk about that a little bit later as well. Engage. And being engaged means they're going to give you a lot of materials. And if it's like most of the boards that I've seen, a lot of the materials may not make a lot of sense to you. So to be engaged, you should take a look at what they send you, and then if you don't understand it, then make some notes and ask questions, because you'll find out that they just generate a lot of information, and you may not understand it. But in order to make your decision, you really need to have a good feel for what's going on. And probably the most important part of what's required of you is what is called your fiduciary duty. And fiduciary means, in general, that you put somebody else's best interest ahead of your own. So it's similar to where when you're making decisions about your children, hopefully you're putting their interest ahead of your own and you're doing what's right for them. So you can see I've got that little picture of me, and where it says me, that isn't me, that's you. It's got the little board member, and you've got the health center there. And your fiduciary duty is to make sure that everything you do benefits the organization as a whole, and also the people that depend on the health center. And this is particularly important for the consumer board members, because you're the eyes and ears of the people that come in and receive their services. And particularly the uninsured and the underinsured, they don't have anywhere to go if the health center wasn't there. So you have to make sure that the services are accessible, affordable, etc. Okay, and we're just about done with this background slide, and then we'll get into the fiscal part. And this is something that comes up a lot, even amongst management, and these two words are policy and procedure. And they get confused a lot. A lot of times we hear policies and procedures, and they tend to be lumped in together. And I think it's very important to differentiate between them, because in general, as a board, you are responsible for policy. You're not so responsible for procedure. And you probably would appreciate it that when you're given materials to review, that you receive just the policies, not the procedures, because the procedures tend to be much longer than the policies. So in a way, you can consider the policy to be a picture of the dinner that's on the menu, and the procedure would be how you cook it. So when you're going to the restaurant, you don't really want to know how to cook the dinner. You're probably better off not knowing how to cook the dinner. In some cases, you just want to be there and make sure it's what you ordered. So this is the formal definition. Policy is a formal guidance. It's something you put together, and it's a big picture plan of what the organization is going to do in a certain area. When you have effective policies, they will make sure that the organization focuses on the really important activities that are going on and doesn't waste their time in a lot of minutia and things that don't matter much. So as a board, you will look at the resources of the organization and you will help set these priorities. They tend to be very general and widespread. They don't change that often. I mean, once in a while, but I wouldn't expect that you would be changing the policies at every board meeting or every other board meeting. That they're generally expressed in broad terms. You wouldn't want to get down to the nitty-gritty. I've seen people that have policies where it says that Susie employee does this and the other employee does that, and that's really not something you'd want in a policy. As a general rule, the policy says what you do and or why you do it. Now let's look at a procedure. The procedure is the operational process required to implement the policy. So again, if the policy is the meal in the restaurant, the procedure is the recipe to cook it. So you all are the diners and the employees are the cook staff, the chefs. So they need to know how to make sure that what they make is what you ordered. It tends to be very narrow. They go down to the smallest details and they tend to each focus one specific area of operations. They can change more often. Anytime there's a change in computer software, there's a change in Medicaid, we get all sorts of changes from the outside. We may have to make adjustments to our procedures, but it probably won't change the policy. It should be expressed in great detail. This doesn't always happen, but what I used to tell people a lot is that, okay, what happens if all of a sudden, there was a plane crash and, your management was gone and somebody had to come in here and figure out how to run this place? Would there be enough detail written down so they could do that? And in a lot of cases, there isn't. And that means that when somebody leaves or something else happens, that the organization's left scrambling. You can tell a procedure because it doesn't talk so much about the what and why you're doing like the policy, but how you're going to do it, when you're going to do it, and who's going to do it. Okay, and now we come down to the 19 program requirements, which, as you can see, they're on tablets. The actual ones are not exactly carved in stone, but in a way they are, because HRSA is very, very insistent that we follow these program requirements, and that will be expected of both the board and the management. Originally, I was thinking I was going to cover a lot more of the program requirements than I did, but seeing this as a 1 hour, we pretty much had to stick to the ones that were directly related to finances. So I addressed these in order. I went through them from 1 to 19, and I started with the lowest numbered one that related to finance. So this order really doesn't have anything to do with how important they are or how they depend on each other. It strictly has to do with how HRSA, in its wisdom, decided to number these agreements. So hopefully you all know what the sliding fee scale discounts are. And on this first slide, what I'm going to do with each of the requirements is I have put in here word for word what HRSA has said the requirement is. So this is not my words, this is theirs. And I've bolded a few words in here, and that is not anything they did. These are just, in my mind, keywords that you as board members would need to understand. HRSA says that the health center has to have a system in place to determine the eligibility for patient discounts on the basis of the patient's ability to pay. Now, you'll see in a while why I thought ability was an important word here, as well as system. And they are actually very specific in what the requirement is. It isn't that complicated. The system has to provide a full discount to individuals or families who have their annual incomes at or below 100% of the federal poverty guidelines. And they say that only a nominal fee can be charged. We'll talk about what nominal means in a bit. The federal poverty guidelines come out every year. They're updated. And there's two sets of them. One set is for the continental United States, and one set is for Alaska and, I believe, Hawaii. We also address the people that make twice as much as the poverty level, 200% of poverty. They can't get any discount at all. Actually, I've got 1 point ahead of myself, I believe. The people that fall in between 100 and 200% of poverty have to be charged something in between the nominal fee that the people below the poverty level are paid and the no sliding fee that is paid to people that are over 200% of federal poverty guidelines. And here my slide is caught up to what I've been saying. Now, the next part is a little bit interesting, and this is exactly what they say. No patient will be denied health care services due to an individual's inability to pay for such services by the health center, assuring that any fees or payments required by the center for such services will be reduced or waived. So basically what they're saying here is that they tell you how you have to discount your fees, and they want to make sure that your fees don't become a barrier to people being able to receive services at the health center. So this is something that's very important. This goes to the very heart of the health center program, because without the sliding fee discount program, we really would be just another medical practice. Now, I like to draw this out in a picture. If you look at this slide over here at the top, it's very simple. The 100% federal poverty guidelines is the middle, the 200 is to the right, and of course zero income is to the left. So between 0 and 100, you see you can charge only a nominal fee. Above 200, there can be no discount. And this actually is a new wrinkle. They have now said there has to be at least 3 categories between 100% and 200% of federal poverty guidelines. I have no idea why, but that's something that they've decided there has to be, so you have to follow that. Now, the first thing, as we pick this apart and try to see how to implement it, this always comes up, what exactly is a family? And the feds and HRSA does not tell us what a family is. They leave that up to the board. So the board gets to define what a family is. When I was growing up, for those of you who don't know who these people are, this is what we got on TV, and this is what a family looked like when I was a kid. Now, I don't have time to throw up every kind of family that exists today, but we've got all sorts of blended families. We've got same-sex marriages that are recognized in different ways in different states. And what I recommend to boards is that they really apply family in the broadest sense possible, because again, our goal here is not to deny anybody service. Our goal here is to fairly provide service at a cost they can provide. So, I mean, obviously it has to do with how the board feels about it, but again, I don't see any benefit to the community of leaving anybody standing outside in the rain. So now that we get past what a family is, then we get our next question. Okay, what exactly is the ability to pay? And I mean, people that have got health insurance, I mean, I'm fortunate. I've had health insurance for the last 4 decades, actually, for my entire life. So when I go into a medical practice and I'm checking out, and the lady at the window asks me how much I want to pay today, I generally, being the wise guy that I am, tell them, well, I don't want to pay anything. I'd rather get it all for free. And then they just look at me and scratch their chin a little bit. And of course, the question is, how much do I have to pay? Well, in the case of a health center, how much you have to pay is determined by their family income. And the rules are fairly well defined. So when somebody is charged a fee that you develop, and this is, again, pictures I use are not typical of our patients anymore these days, but these are copyright-free pictures that I don't have to worry about the owner coming after me for using. And I mean, these are clearly poor people. We serve a lot of poor people. People whose family income doesn't qualify them for a full discount, or maybe they didn't bring in any of their proof. So they can, you can have rules to allow them to have a visit or two without proof, but generally they eventually are going to have to bring in some proof of income. And for whatever reason, if your system determines they have the ability to pay, that really doesn't relate to how much money they want to pay and what they have in their pocket today. And again, I'm dating myself here a little bit, but in the old days when we watched Gilligan's Island on Sunday night, we had the millionaire that was on the island, but he didn't like to spend his money on it. So again, when you determine what people should be able to pay, that doesn't really mean how much they're willing to pay, and you have to have some way to deal with that. Okay. Finally, you know, we have to look at our sliding fee scale and say, okay, how is this going to affect the patient and how is it going to affect the health system? And basically, what we have here is it's more of a continuum. So as we make our fees lower and lower and the sliding fee more and more generous, the health center obviously is not collecting any money, and most of the time they need that money to keep operating. So we want to collect enough so that we actually can stay in business and provide the kind of high quality care that we're expected to. On the other hand, if we make the fees so high that people really can't afford them, even with the discount, then they're going to start thinking twice before they come in, and that means they're not going to come into the health center, and that means that they may end up getting their care in the emergency room, which is not good for them, it's not good for us, and it's not good for the healthcare system as a whole. So we don't want to do that. We want to make sure that our fees strike a balance between providing the funds we need and not providing a barrier to getting it. Okay, now I'm just going to get a little bit farther into the weeds here, and basically what we're looking at is these would be two patients here. Okay, one of them qualifies for the sliding fee scale, the one on the left, the one on the right does. Our full fee for a visit is $150. These are just numbers I've made up. They don't come from anywhere. So let's say we have a $150 fee and we have a minimum or a slide of $40. So how do we get paid for this visit? Well, $110, the part that's in the orange, that comes out of our federal grant. And the other $40 comes from the patient. That's where we get our $150. Now, if the patient doesn't qualify for a slide, then they would be charged $150. So they pay that $150. Either way, if things are working the way we hope they're working, we wind up with $300 that we can use to pay our employees, provide care. However, $150 could be a bit of a barrier. I mean, that's quite a bit of money for anybody to pay for a medical visit, even if you're insured. So now we have another thing. We got the Dr. Doolittle clinic down the road. That could be in a Walmart or a CVS or just a private doc, and basically they're charging $100 a visit. So what are we supposed to do? If we continue to charge $150 and they charge $100, we're going to lose a lot of people that would otherwise come to us. But we're not allowed to give a sliding fee discount to anybody who's over 100% of poverty. So what are we supposed to do? If you look back at the rule, it just talks about sliding fee scale discounts. There are actually other things we can do. Now, one of the tests they put on us, of the two tests of our fee schedule, is they have to be market-based, which means typical. The full fee has to be typical of what people would pay in a private practice, and they have to cover our costs. So $150 is probably close to what a typical health center's cost per visit would be, or their Medicaid rate. $100, probably less. So the market rate and the cost don't always match up. So how do we get the $150 down to $100 so we can compete? Well, one of the ways to do this is with a prompt pay discount. And a lot of health centers are starting to do this. I did this at my health center for years. And basically, when a patient walks out and doesn't pay, there's a lot of activity that has to go on. You have to send them a bill. You have to fine them. It's a lot easier if they just pay you at the time that they come in. These days, a lot more people have credit and debit cards. So what we do is we can offer them a discount for paying today. Now, 1/3 is a bit on the high side for a discount, but on the other hand, these aren't real numbers, and HRSA doesn't tell us exactly how much we can give, but they have actually addressed prompt discounts and allow us to give them. The only thing is we have to do it across the board. If we're going to offer it to some of the patients, we have to offer it to all of the patients. But these are just some of the ways we can compete in the marketplace despite all of the rules that HRSA puts on. Okay. Number 10 was contractual and affiliation agreement. And they don't say much about this. All they say is the health center has to exercise appropriate oversight and authority over all contracted services, including subrecipients. All right, so we're going to talk about that a little bit. All contracted services. So basically, as a board, you are responsible for these contracts. So at a minimum, you should know what they are and make sure that they're happening at some sort of a defensible market rate. Now, let's talk about the two they mentioned here, okay? Let's look at the doc on the left is an employee of the health center. The doc on the right, however, may work for another medical group or may just be working for themselves. And instead of them being an employee of the health center, they work for us contractually. They might only work part-time or they might help us cover nights and weekends or something like that. And of course, the IRS helps define what's an employee and what's a contractor. But assuming we meet all those tests, what's the difference between these two employees? Well, here's the thing. There really isn't one. I mean, we pay them differently. There's taxing differences and everything else. But as a board, you have to make sure that the doctor on the right, who is not your employee, and the doctor on the left are credentialed the same way, they meet all the same standards and everything else, because they're going to be held to those standards. The next item they discussed was a subrecipient agreement. And drew a simple little picture here. Basically, in a subrecipient agreement, what happens is that instead of an organization getting a grant from HRSA, you get the grant from HRSA, and you decide that rather than performing the services yourself, you will make someone else a subrecipient. So you will pass the money on to them, and they'll be responsible for the services. So what's the difference between that and the contract on the left? Well, the contract on the left, this person is under your direct day-to-day control, so you're responsible for everything as they were an employee. The medical group they work for can be a for-profit medical group or not. HRSA doesn't care. Under a subrecipient agreement, the subrecipient has to meet all the same qualities that you do. And basically, they have to have a compliant board and everything else, and they manage the details of the services, but you still are responsible for everything they do. So if it's sort of like if you sublease an apartment, if the tenant that you've subleased to destroys the place and runs away, the landlord's going to look to you to make good on it. You're going to get these agreements, and I mean, a lot of them are complicated, and it's puzzling why they're doing that way. It's really beyond the scope of this to talk about all the different agreements that can be out there. So we just need to talk about the questions you should ask. Why are we doing this contractually instead of doing it ourselves? Maybe it's not in the core competency of what the health center does. What's the cost? You know, again, sometimes it's cheaper to contract something out, and there's also something called opportunity cost, which means that we only have so much time and so much attention. So is this the best use of our time, or can we just hire somebody else to do this for us? Okay, what's the benefit? And sometimes something can have a high cost, and the benefit is so great that it outweighs the cost, and you still decide to do that. That's really common with some IT contracts for providing electronic records and such that are very expensive, but when you look at the improvement they make to the care and your productivity potentially, it may be worth doing it even though it's expensive. What are the risks? And again, you know, people are generally not very good at assessing risk, and you really have to look deeply and say, okay, what's the worst case scenario? Because pretty much I like to assume Murphy's Law is true, and whatever can happen will happen at the worst possible time. And when I'm doing a webinar, the power will probably go off and lightning will hit the house. I mean, that's just everything you've got to assume. So what's the worst case scenario? What can happen? And are we protected? And how are we going to monitor the arrangement? Just because you've contracted it to somebody else, particularly if it's a required service, you are still responsible for it. So you better be keeping an eye on it. Okay, moving right along, and we're moving on to financial management and control policies. Now, this sounds pretty dry and pretty awful, but basically it says you maintain accounting and internal control systems appropriate to the size and complexity of your organization, reflecting generally accepted accounting principles, and separates function appropriate to organizational size to safeguard your assets and maintain financial stability. And basically, as a board, when I first started at the health center over 30 years ago, what typically happened was that there was 1 million policies and 1 million procedures, and they were bound in a book, and the book was dropped in front of the board members who looked at it until their eyes glazed over, and then they didn't understand anything they read, but they had to sign off on it because it was a requirement, and that's it. But nowadays, things are a little different. In some ways, they're more complicated. So it's important that we get away from just what it says has to be done in the details, and I'll explain how that works later. And we really need to look at what these policies mean for the health and welfare of the organization. Now, here you have to have an annual independent financial audit performed in accordance with federal audit requirements. So this basically is what's called an A-133 audit, and health centers have to have these every year. And the most important thing about them is that the auditor will explain the findings in a way that makes some sense to you, so you don't just hear a bunch of words that you don't understand. So how have things changed, and how does that affect us? A few years ago, and I guess I'm dating myself here, we did have some systems in place to run a health center, and this is the picture here. And without going into excruciating detail, what I will say is, you notice in the middle, there's this figure of the poor accountant and all these reports that have to go out, the UDS, finance reports for management and the board, cost reports to the state for Medicaid. These were all done by hand. We did have a payroll system. We did have a practice management system. We had a pharmacy, and then it was able to provide prescriptions. But everything throughout paper reports, there were paper paychecks that were handed to the patient. Somebody had to drive around to all the sites. And you see that the accountant in the middle of it had to take all this data from these different systems and try to produce these reports. The practice management system also threw out printed insurance claims, which had to be checked, mailed, sent to the payer, tracked, and we used to mail patients all their bills, many of which came back as undeliverable. As I could see when I went to my last doctor's appointment, and the timing was opportune, and what are they doing? They are hauling away the medical record shelves from this giant group practice because they have no more paper records. And that's the way it is at most health centers now. Somewhere about 95 to 98% of health centers now have some sort of electronic health record, which is way higher than the general medical community. So this is just a very, believe it or not, this is a simplified diagram of what a typical health center system connects to these days. And I mean, going over it real fast, you can see that there's some of the old systems are still there. We still have the practice management and our general ledger and accounting system, our pharmacy system, but there's some new systems we didn't have. And what we call business intelligence is popping up more and more. There's so much data that's going through our hands that we basically need to have our own software just to make sense out of it. Okay? Generally, our billing does not go directly to the payers and the patients anymore, but it goes through a clearinghouse because there's so much work that has to be done to manage. The patients, you notice there's a computer that the patient has. Even health center patients have computers these days, and they're able to get their bills electronically if they want, and they can access their medical records through the health information exchange. So the patient's more involved in their care as well. All of the federal computer systems, more and more has been computerized. The things we used to send in writing, like our grants and all of our UDS, are now done electronically through the very spiffy federal government systems. The states have systems, and more we're hooking up to other people's computer systems, hospitals and other medical groups. Our payroll is generally done by direct deposit, electronic funds transfer. We now can check eligibilities on people online before they come in. And it's just a much more complicated system than before. But if you do it right, it can provide you with a lot more information. Now, you notice up in the upper right, a couple things we didn't have before are the hackers and the news outlets. Of course, these days there's been a lot of hacking of medical data. So as a health center and a health center board member, what you should be making sure is that your data is safe. And you need to ask those questions, because if somebody hacks the health center data, it's a big problem for the health center. It costs a lot of money to fix, bad publicity. News outlets simply means, in the old days, if somebody wanted to look at our 990 form, they had to come by the health center, take a look at it. Now it's all available on the internet, and HRSA has made a lot of our data available on the internet for consumers and newspaper reporters alike to report on and comment on. And then we get to the things that it says we have to do every day. Without going into great detail, you have to have a qualified CPA firm provide your audit. Now, to me, any CPA firm that's licensed in a way is qualified, but to me, what qualifies them is, have they done what's called an A133 audit of organizations like ours, and even better, health center audits. This is important, and auditors are getting much better about this. They need to come and present the audit to you and explain what things mean so you understand it, particularly the fact that an audit is just that. It doesn't mean that everything is okay. It just means that they tested it and they didn't find anything wrong. There's a big difference between that. The board has to approve the financial policies of the organization. This is why I pointed out the difference between policies and procedures. They ought to be fairly short and understandable. Okay, let's talk about billing and collection a little bit. And again, all they give us is a paragraph. It says the health center has systems in place to maximize collections and reimbursements for its costs in providing health services, including written, billing, credit, and collection policies and procedures. So, as we said earlier, you should understand and approve the policies, and management should approve the procedures. Why do we have this? And this is just a graphic of the old saying, no money, no mission. So if we don't do our job right, bill and collect, then we are not going to be able to stay in business. This is an area that gets confused a lot, the difference between the fee schedule and the sliding fee schedule, particularly now that more and more health centers have a flat fee for their patients on the sliding fee schedule. The fee schedule is the full fee for a procedure or a bundled group of procedures before any discounts are applied. And we're going to see why that's important in a minute. Again, most health center board members, because most of the people they know were getting sliding fee scales, they were worried about how much $10 or $20 they pay. But as more and more people are getting insured under affordable care, and Medicare has improved how it pays FQHCs dramatically, it's important that we capture the full fees of what was done, and we set those appropriately. If you look at the marketplace, in most cases, your fee schedule is not what you're actually paying. And if it is, it means your fees are probably too low. So anybody who's got private insurance has probably gotten something back from Blue Cross or whoever your insurer is, and it says your doctor billed them for $300 and they paid like $30. And basically, that's very typical. And it's understood you're supposed to set your fees at where everybody else sets their fees. You need to cover your costs. And the difference between what they pay and what your fees are just adjustments. And this all has to get reported to HRSA and the UDS. And it means that you are capturing everything you did. Okay? So we don't ever want to set the fee schedule too low. If payers are paying your entire charge, your fee schedule is most likely too low. And basically at health centers, I've seen a lot of health center fee schedules. Most of them are set too low because the feeling is that the patient shouldn't have to pay too much, which is true, but you've got to remember that's what the sliding fee scale is for. So if we set the fees too low and the sliding fee scale is added on top of it, then the fees they pay are way too low. So again, here's another one of these graphics I've got here. If you look on the left, these are the expenses of the health center. in general. If you look on the right, on the bottom is the money we get from HRSA. Above it is the money we get from everywhere else. So in general, your expenses have to equal your income. And you notice on the top where I say reserves, if this were a for-profit business, that would be called profit. But in a health center, because we put our money back into our program, generally the money that's left over would go into reserves. Now, let's break it into a little more detail. Okay, the HRSA grant piece stays the same. If you look at the generated income, though, this is very typical of a health center, where their other income comes from. You see that the majority of it comes from Medicaid these days, even more than the HRSA grant. Often, then they generally get some state and local grants. You see how much the patients are paying, a little bit of private insurance, and not much Medicare. Now, if you look at these arrows, the colors actually mean something. The more red it is, the more important it is that you set your fees at the right schedule. Private insurance, it's vitally important, because if you bill them too low, you're going to leave money on the table. Self-pay, it's important because it needs to go into your sliding fee calculation. For your other grants and your HRSA grant and Medicare, it traditionally hasn't been that important, because no matter what your fees were, you got paid pretty much the same thing. Now, let's look at where things are going. And this is not necessarily here, but in some states it's getting here. The whole system seems to be heading this direction. A few things you notice. The HRSA grants are getting smaller. Now, that hasn't really happened yet, but we've had some warning signs from HRSA. They now are telling us that if you don't have the number of patients that you said you would have, you're going to get a cut to your grant. But the real reason the grants are going to get smaller, I believe, is because with the Affordable Care Act and with expanded Medicaid, more and more people are going to have some method of payment and will be less reliant on grant funds. So that means that your ability to bill third parties and attract these patients has to be enhanced, or you are going to lose money. So Medicaid should be growing. Other grants have generally been shrinking, and the self-pay is obviously going to shrink because more and more people are required to be insured by the Affordable Care Act. Private insurance is definitely growing because that's the Affordable Care Act. And if you look at Medicare, there's a new Medicare prospective payment system, which is a day-long seminar in itself. But basically, the rates that health centers are paid by Medicare is better than pretty much any other primary care provider. So if your health center hasn't been doing a lot of Medicare, you really should be asking why and take a closer look at it. Now, if you look at the importance here, you notice that more of these indicators are turning red. Medicare will pay you the lesser of your charges for these bundled codes that they pay on, or the actual cap that they set in your area. And I can't tell you how many health centers are setting their own fees lower than the amount Medicare said is appropriate, and they are leaving major money on the table. Private insurance is important. Self-pay remains important. And again, HRSA, not quite as important. Medicaid, because we're generally paid on a cost-based basis, your fees are not overly important. So billing is one thing, but look at all the things that have to happen before you get paid. I mean, imagine that, okay, you've done the service and everything else, now how's the money coming in? So this is sort of a bunch of screens that this goes through. Were our fees set correctly? If we set them too low, then obviously we're going to be losing money. Do we have the best payer rates? Now, what does that mean? Many health centers are shocked when I tell them that payers are willing to negotiate rates. I work with some people in managed care, and they have told me that they have gone into negotiations with health centers prepared to pay a certain amount of money. They put their first offer on the table, and the health center says, okay, and they sign. So it would be like walking into a car lot and basically agreeing to pay whatever was on the sticker of the car without even talking about it. So that's something that health centers need to get a little better at. Are the providers credentialed? And when I say credentialed, I don't mean the way you credential them to actually practice in your organization. I mean, are they signed up with the insurance company? I can't tell you how many claims are denied because the provider has not been properly credentialed with the insurance plan. And a lot of insurance plans know that, and they go slowly to credential the providers. But you need to make sure everybody that's seeing the patients for them actually has been signed up so you can get paid. Are they actually getting the insurance information from the patients? Often they're not. And if they're not, then basically you don't even send a bill in the first place. Are you coding the visits properly? Most of private world is being monitored because they tend to code their visits higher. They tend to say they did more work than they did. Health centers are different. Health centers generally say they did less work than they did, and that's just based on our history of being more worried about delivering the care to the patient at the lowest possible cost. And once we finally submit these claims, are they going in properly, and is somebody actually following up on the ones that aren't paid? A lot of claims are properly submitted, and something goes wrong and they're not paid, and the health center never follows up, and they lose the money. So by the time your dollar goes through all these screens, you know, there might only be a nickel left on the bottom. So we need to get much better at that as a group. The times, they are changing, big time. So when I started many, many years ago, we basically had what I'd call a low accountability grant model. And basically, we had to be open certain hours. You know, they rewarded us because we had X number of people that were working there. And they didn't really know what they wanted as an outcome. I mean, we had to report how many people we saw, but they really didn't ask a lot of questions about how healthy they were, anything else. And there was absolutely no focus on how much it costs to provide the care. Here's how much money we're giving you. And believe it or not, if we ran low on money, we would call the federal government up and they would just send some more. This doesn't happen very often. There's some private and state grants that do this, but nobody else. So these things have gone the way of the dodo bird. Now, HRSA is what I call a grant-based high accountability model. They want to see some outcomes for it. So they don't just want to know how much money they spent. They want to know what they got for their money, okay? They want us to help a general population, and it's an appropriate way to work with uninsured populations because there's no other payment mechanism to get somebody to see them. They tend to focus on broad outcomes. How healthy in general have we made the population? It's still difficult to control costs, and basically the accountability is mostly based on volume. They want to know how many people you saw. HRSA is going to cut your funding if you don't see enough, and that's it. Now, a volume-based system is how most traditional insurance works, and basically you get paid by the visits. So the more visits you do, the more money you get. Okay, well, that's great. Okay, but if you paid the car repair shop that way, you'd be paying them every time you bought the car back, not for fixing it. So there's problems with that. You got to have productivity. You've got to see more patients, but there's no reward for seeing people that are sicker. If you see people that are sicker, it takes more time. So everybody wants to get the easy ones and send the hard ones somewhere else. There's no reward for good outcomes. They just want to know how many visits you had. But the costs have grown out of control, and basically the Medicaid PPS systems still follow this methodology, but they're starting to move away from it. The next group is an intensity-based encounter system, and basically it still pays for visits, it still rewards productivity, but it does recognize that some visits are harder than others, and it will pay you more for those. It still doesn't focus on outcomes. It's still hard to control costs. And our Medicare PPS system is a good example of this because it's going to allow more payment for visits that are harder to do. And then this is what the whole world is moving to, value-based, outcome-based. And basically, they want to see results. They want to see healthy people. They're less interested in how many times you saw them. It rewards you doing a good job at managing your patient population, and it rewards you for being efficient. This is very important. It gives you a risk adjustment. So in order to get you to take sicker people, it says, okay, sicker people are harder to manage, so we will pay you more people if you're managing sick people. It wants to see what the outcome was. It doesn't care how hard you work. It just wants to see if the patient got better. It's a great way to control costs, and it's also really the best thing for the patient if it's done properly. And what's called accountable care organizations are a good example of this. All these changes require data, and you are going to see large numbers of data coming in and out, and the important thing is that somebody is looking at all of this. Okay, and we're getting near the end, and I'm just about out of time, so excuse me for speaking so quickly. We have to have a budget at the health center. They want to see that we've developed a budget that reflects our costs, expenses, and revenues, which pretty much this is the definition of a budget, and they want to see how many people we're going to serve with that budget. Okay, so what does this mean? When you look at the budget, you got to see, does this make sense to you? And is it realistic? I've seen budgets where they say they're going to produce a certain amount of work, and basically they'd have to be open 45 hours a day, 9 days a week to do that. That probably isn't going to happen. Okay, this should be monitored monthly. You should get reports and see how you're doing on your budget. And the last couple of slides have to do with the board authority, and we're going to send out PDFs of this. So I'm not going to read this whole thing. The important thing is the second bullet, that you approve the health center's grant application and their budget. You're responsible for that. So we're going to look at this is the last slide. We're going to look at the board authority over finance and a nice little pyramid here. And basically, the whole board cannot be expected to monitor the finance. So you pick a committee that monitors the finance, and you elect a treasurer. So the committee should be meeting with the CFO and the finance staff every month, and the treasurer should be giving the finance report with the help of the CFO to the board, and the board should look to the finance committee and the treasurer to handle the details of the health center finances. And I am out of time. So, and I did not get any questions. So either everyone is asleep or I answered most of what you wanted to know. So if anybody has any questions, you have my contact information, feel free to send it. Christina, turn it back over to you.
Thank you, Steve, so much. I'm going to put your contact information on the screen so everyone can jot that down quickly. You will be receiving, in just a few minutes, an evaluation. If you could please fill that out and also share that with those who were also on the call with you. If you can share that evaluation with them, and we will also be sending the slides along with the evaluation. So that PDF will come through with your eval. So that should be in just a few minutes or later this afternoon. Thanks again, Steve, for that wonderful presentation. We appreciate it. Thank you, everyone.